So today we're going to discuss about the diagnostic test accuracy network meta-analysis methods. My name is Areti-Angeliki Veroniki. I'm a scientist at St. Michael's Hospital, Unity Health Toronto, and an assistant professor at the IHBME University of Toronto. And together with Dr. Sofia Tsokani from the Method Support Unit at the Central Executive Team in Cochrane and from the University of Ioannina in Greece, we're going to present this topic. Before I start, I would like to also acknowledge the land of Toronto, which is known as Karonto and is the traditional territory of many groups and nations. And we would like to honor the elders and knowledge keepers, both past and present. And we acknowledge the harms of the past and the present, and we dedicate ourselves to work with and listen to the First Nations. And we recognize and are grateful to have the opportunity to work on this land. So in today's session, we will give a brief introduction to the diagnostic test accuracy studies, how these studies that address the same research question and assess the same diagnostic test can be combined in a diagnostic test accuracy meta-analysis. We will present the systematic review process of a diagnostic test accuracy meta-analysis and the relevant meta-analysis methods. And then we will extend the diagnostic test accuracy meta-analysis to network meta-analysis, how this can be built with in a network geometry, and what are the implications in conducting a DTA-NMA. I assume that most of the people here are familiar with systematic reviews, but in any case, I will give a very short introduction to the systematic reviews. So a systematic review is a method used to synthesize all the relevant evidence from the individual studies on a specific topic and a research question. So in a systematic review, we interpret the results within the context of the global evidence on the totality of the study results. And we are able to explore potential variation or disagreements across the studies. So systematic reviews can focus on assessing the efficacy or safety of interventions or medications, but they can also be used to evaluate the diagnostic accuracy of index tests to identify a certain condition based on a reference standard that we choose. So systematic reviews can also include the quantitative synthesis of the individual study results, which we refer to the meta-analysis technique. And we are able to obtain a more powerful result when we synthesize all this evidence, and we can explore the between study heterogeneity in these observed effects of the individual studies. Now, the diagnosis of a medical condition is an important step in healthcare decision-making. And diagnostic tests are used to clarify whether an individual has or does not have a disease, a target condition. But most tests, which we often call index tests, are imperfect. And they are imperfect in the sense that they cannot always discriminate between the patients with or without the disease. So the diagnostic accuracy of the tests, in that case, it should be evaluated. And when we mention diagnostic accuracy, we refer to the ability of a test to correctly detect the presence or not of the disease. And to do this, we use the reference standards. A reference standard we consider to be a reliable test, which we use to infer on the presence or absence of the disease for the specific test of interest. And index tests usually provide a binary outcome, a positive or a negative test result. For example, we may have individuals, when we perform the test, the rapid test, for example, for COVID-19, to detect the COVID-19, we may have positive test results and or negative test results. But there may be continuous index tests, like the blood tests, for example, and these require setting a specific cutoff threshold in order to dichotomize the test results. The diagnostic performance of index tests is commonly described using two specific concepts, two specific measures, that is the sensitivity and specificity. So sensitivity gives us the proportion of those individuals with the disease that the test detects. So it describes the ability of a test to correctly identify the diseased individuals. Specificity gives us the proportion of those without the disease that the test gets right. So it describes the ability of a test to correctly identify the non-diseased individuals. Now, let us consider this example where we have an index test, a rapid antigen test for detecting the COVID-19 or the SARS-CoV-2 infection. And in total, we have in the study 130 participants. 30 of those participants were truly diseased according to the reference standard, and 100 individuals were non-diseased according to the reference standard. So we can see that we also have the 2x2 table. We have the true positives, false negatives, and true negatives. So these are the results from the specific study. And using these results, we can calculate the sensitivity and specificity for the specific test to describe how well the specific rapid test performs in those with and without the disease or the COVID-19 infection. So the sensitivity, as we see here, showed that a positive test result identifies those with the disease in the 90% of the cases, whereas specificity showed that a negative test result identifies those without the disease in the 98% of the cases. As we can see now here, the specific test has a high specificity, I would say, and we can use the specific test in order to rule out the presence of the disease. And this is particularly helpful because we use the rapid tests usually in people with symptoms who have potential symptoms or have been in contact with a confirmed case or a confirmed exposure. But in general, we need both sensitivity and specificity, and of course it is crucial to always report both measures in order to make a decision whether we want to use the specific test or not. The ideal test now has both sensitivity and specificity close to 100%. So that false negatives, false positives are the number of those is very small and they are close to zero. But unfortunately, having tests with 100% of sensitivity and 100% of specificity are very uncommon in real life. And the choice between the optimal, let's say, sensitivity and specificity depends on the question and the setting that we want to apply the specific test. Now, there are several measures that we can use to assess the test performance. Apart from sensitivity and specificity, we have, for example, the positive predicted value, the negative predicted value, or diagnostic odds ratio. I'm not going to get into the details of these measures. If you want to have a look and maybe get more information around these measures, maybe you can have a look at the paper by Sofia et al. And I'm only focusing right now on the sensitivity and specificity because the models that we're going to discuss in the next few slides are actually based on those specific measures. Now, as we said, diagnostic tests may be binary markers like the X-rays, for example, which directly indicate the presence or absence of the disease. But we may also have continuous or ordinal tests, such as the blood tests that we said before. And in this case, we need to set a cutoff value, a cutoff point, the threshold that we usually call, according to which we are going to decide on the test positivity. So the threshold, for example, here, dichotomizes the continuous test into negative and positive results. Now, as the threshold is set in different points, there is a trade-off between sensitivity and specificity. The ideal scenario would be that there is no overlap in the distribution of the test measurements, the true negatives, let's say, and the true positives in the diseased and non-diseased. However, there is no perfect discrimination in tests usually, and this will be never the case in real life. And as we can see in those plots in the A, B, and C, the distribution of the test results with for those with the disease and without the disease, they overlap. So You can see here the shaded areas. So the shaded area in green shows us the false negative results. And the shaded area in yellow shows us the false positive results. So increasing now the threshold from 100 here in the A plot to, let's say, 110, the proportion of those without the disease increases. And therefore, as we can see, the specificity has also increased. So higher thresholds produce more true negatives and increase specificity, but as you can see, sensitivity decreases. Similarly, if we decrease the threshold from 100 to, let's say, 90 here in the plot C, we can see that specificity decreases from 90% here to 70%, and sensitivity again will increase. So lower thresholds produce more true positives and decrease specificity, but sensitivity will increase. As you can see, there is a trade-off between sensitivity and specificity with the threshold as we change it, as we move it to different points, and that's something that we need to consider. Now, on the meta-analysis level, our goal is to give an overview of the performance of the diagnostic test. And diagnostic test accuracy meta-analysis use usually one pair of sensitivity and specificity from each study. So each of the individual studies contributes the 2x2 table that we saw earlier. Now, when we have similar thresholds, we estimate the pooled sensitivity and specificity with the confidence regions, the uncertainty around that. But when we have varying thresholds, we're able to calculate, to estimate the summary log curve to describe the change between the sensitivity and specificity across the thresholds. But importantly, within each study, sensitivity and specificity are independent, and that's because they are estimated from different populations. We have the disease for the sensitivity and the non-diseased population for the specificity. Now, across the studies, sensitivity and specificity are generally negatively correlated. So as one decreases, the other one will increase and vice versa. And in order to account for this correlation, we need to multivariate models to account for that. Now, let us start with the steps of the systematic review of a diagnostic test accuracy, meta-analysis. So the steps are similar to the ones that we follow in systematic review of interventions. And as a number one step, let's say, we start by defining the question. So the question usually reflects the review objectives and the eligibility criteria, let's say, of the review. So, for example, in our systematic review of diagnostic test accuracy studies, the review question was, what is the diagnostic accuracy of rapid antigen and rapid molecular tests for the diagnosis of SARS-CoV-2 infection in both adults and children, according to the reference standard PCR test? Now, having identified the clinical question, we need to also define the PICO criteria. So in intervention studies, we have the PICO criteria, but in DTA reviews, this will be slightly different, and this will be the PIT acronym, where we have the population, and we call it population instead of patients because we usually have non-disease as well, population, non-diseased individuals, or asymptomatic patients. So we have the population, we have the index tests, and we have the target condition. So for the population, we usually define the characteristics of the population, the age, the sex, the setting, similar to what we have done here, where we say that we include, for example, adults and children who were screened or suspected for COVID-19. Then we have the index tests, where we define the tests of interest that we want to explore to assess the potentially of the test, if the test is an add-on, if it is a replacement or a triage, any comparators, any test comparators that we are interested in. And again, we need to define the reference standard that we are going to assess the specific tests. And also as a T, the target condition, instead of having the outcome that we would have in the PICO criteria in a systematic review of interventions, we have the target condition. And here we, for example, here we have said that the target condition is the SARS-CoV-2 infection. So it's very important to start with the review question and the PIT criteria. Now, as a second step, we need to define the objectives of a diagnostic test accuracy systematic review. So, for example, the objective, usually the primary objective is to estimate the accuracy of an index test versus a reference standard for a particular threshold, for example. So we need to be very clear on what we plan to estimate and what we plan to compare. Now, as objectives, we may have, we may separate this as a primary objective and a secondary objective. So the primary objective is usually to assess the accuracy of the index test for the diagnosis of the disease in the specific population of interest. And as a secondary objective, we may want to explore the differences in the accuracy of the test between subgroups or variations of the index tests, let's say different thresholds or different manufacturers of the test, and so on. Then we move on to the third step, where we develop the protocol. So here we need to clearly describe all these PIT criteria and the methods that we're going to use to assess the test. Of course, the eligibility criteria that we said earlier, any assessment of the studies, the risk of bias and applicability, the data abstraction processes, the models that we want to perform, and so on. And of course, we need to be very transparent on what we plan to do on the methods. And in the end, we may want to register the protocol with Prospero, for example, or we may want to publish it in an open access journal after peer review. As a fourth step, we search for the studies, the relevant studies. We usually search at least two databases. For example, Medline, Embase, or Central. We may want to search specific databases to the target condition if they are available. We usually check the references of the included studies. We also check also the gray literature or contact experts. So we follow the same process as an intervention, a systematic review of interventions. But of course, we need, for searching the studies, we need to seek guidance from a librarian, ideally with previous expertise and experience in this DTA systematic reviews. For example, in our systematic review, in our rapid review, actually, of DTA studies on the COVID-19 tests, we used an experienced librarian actually developed the certs. A second experienced librarian also peer-reviewed the certs. And then from the specific certs, we found around 5,000 studies. So we screened those 5,000 studies. This is a typical number in DTA reviews. And we ended up with around 90 or 95 studies that were eligible in the network meta-analysis in the end. So usually, systematic reviews of DTA studies find a lot of studies, and we end up with a few only. So as a fifth step, we move forward to screen the relevant studies that we identified, and then the data abstraction. And the screening process to decide the relevance of the studies is usually conducted by two peer reviewers independently. And again, we require a good agreement between the two peer reviewers. So all these steps should be documented in the final paper, and of course, following the PRISMA for DTA systematic reviews guidelines. Now, as a sixth step, we assess the risk of bias and applicability of the included studies. We usually use a standardized assessment tool that might be the QUADAS-2 and the QUADAS-C tools that have been suggested for the diagnostic test accuracy studies. And we focus on risk of bias and applicability and not the reporting of the studies. So we assess for the bias, the degree to which the estimates of the diagnostic accuracy are different or deviate from the truth. And the applicability in the sense that the primary studies actually are applicable to the review question that we are interested in exploring. And this applicability actually may be problematic sometimes regarding the population or the reference standard. So these things should be certainly mentioned in the review. And usually when we assess the risk of bias, we use two assessors. Now, the next step is usually the meta-analysis in order to obtain robust conclusions with respect to the research question. And we discuss the methods of course, in the paper. But overall, as I said, we have to follow a very clear process, as we said here. We need to have an effective and efficient searching of the studies. We select the studies, we assess the applicability and risk of bias of those. And then we interpret and analyze the results using the methods that we're going to see in the next few slides. But as a ninth step, we may also want to update and improve the review based on new studies that might be available. But I want to highlight here that it is of major importance to be transparent in the reporting. Of course, when we are transparent in the reporting, we reduce research waste. And we need to follow the PRISMA DTA guidelines. So two important items that we need to report in our systematic review of diagnostic test accuracy studies is the reporting of the uninterpretable or void results of the tests, and also how many withdrawals we may have from the study and why those happened. There should be an explanation of that because this might be also associated with the test. So things like this should be reported in our review. Now, the general meta-analysis process involves calculation of the weighted average, increasing precision and power versus the individual studies, of course. And we also are able to evaluate the heterogeneity, investigate reasons for this variation when we find heterogeneity. So that's the regular process in intervention reviews. So what is so critical in our systematic review of diagnostic test accuracy studies? And that is the test threshold. So we should not ignore the different test thresholds in the meta-analysis. And we should always ask, when we combine the results across the different thresholds, whether this makes sense, clinical sense, whether we can interpret those results, and whether the different characteristics, for example, of the studies may impact on those results if they make sense, of course. And something that I want to highlight here is that thresholds are not only important for the index test, but also for the reference tests. So thresholds might be, should be accounted for both sides. Now, a key challenge in DTA reviews is that we have two summary statistics for or from its diagnostic test accuracy study. We have the sensitivity and the specificity measures. And as we said, those two measures are correlated across the studies. Another challenge also is that we have heterogeneity. And heterogeneity, in contrast to intervention reviews, here in the DTA reviews, heterogeneity is the norm rather than the exception. And this should also be accounted in the models and in the interpretation. So the general meta-analysis models process actually obtains a single estimate. So that should be avoided because this would be a biased approach. So it ignores the threshold and it actually gets shows us results from based on the studies that have high sensitivity and specificity. So it gives us more biased results compared to the models that we're going to see in the next few slides. So overall, we have two models as we're going to see. We have one model that estimates an average sensitivity and specificity point, and a second model that actually estimates the underlying ROC curve based on the different thresholds. And since currently these are the two models, there are several other models that Sofia also probably is going to touch base on, but these are the most popular hierarchical models that we apply in a DTA systematic review, and they both account for the within and between study variability, the heterogeneity, and the correlations between the diseased and non-diseased, the threshold effect. So we have the bivariate model that actually gives us a single threshold and the uncertainty around a single summary point and the uncertainty around this summary point. And also we have the HS-ROC model that accounts for the different thresholds across the studies. So the choice between the two, so as we said, we have two models, the Reitsma model or the bivariate model and the Reuter-Gachonis model, our HS-ROC model. So the choice between the two depends on the data that we have and the research question. So whether on all the studies that we have in the data sets apply the same, use the same threshold for the test positivity, or whether all the different studies have different thresholds and it would potentially be most appropriate to estimate an SROC curve instead of the summary point estimate. But both can actually perform a meta-regression, let's say. It can be extended to a meta-regression model where we can add covariates to assess potential characteristics, potential effect modifiers, to explore heterogeneity, for example, further. And I'll stop here and I'll ask Sofia to continue. Thank you.
Yeah, so far, as Arzi explained, we've seen that there are some challenges that we face when it comes to meta-analysis of DTA studies for a single test, including the bivariate nature of the data. So we have two statistics, sensitivity and specificity, which we have to deal with, and we need to take the models that we're going to use to take into account the threshold effect and the trade-off between them. Also, heterogeneity is expected, and we cannot perform separate meta-analysis of sensitivity and specificity estimates, as this approach does not consider this trade-off between sensitivity and specificity. So we've seen that there are two hierarchical models, the bivariate and the HS-ROC model, and in the absence of covariates, these two models are equivalent. However, both models require that each of the included study contributes results on a single threshold. So there are cases where studies may report results for more than one threshold. And in this case, even the HS-ROC model, which accounts for the threshold effect, but both models do not account for the threshold values per se. So there are additional models suggested in the literature, like the Steinhauser model, which is a mixed effect model and takes into account all these values. So if we move to the next slide, we can see a meta-analysis, an example of a meta-analysis. In this meta-analysis, the aim was to explore the diagnostic accuracy of an index test, the Film-Murray meningitis encephalitis test, in patients with suspected central nervous system infection. So the target condition was the central nervous system infection. This meta-analysis included 16 studies and around 6,000 participants, and we adopted the bivariate model to conduct the meta-analysis, and we summarized the information coming from all these studies in a summary point, and we have the summary sensitivity and specificity. The summary sensitivity was estimated to be 89.5%. That is, that the test correctly identified 89.5% of the individuals who had actually the disease, while the specificity was very high and was around 97%, which means that the test correctly identified can correctly identify 97% of the non-diseased individuals. Of course, when we interpret results, we need to take into account the quality of studies, and we should assess the risk of bias, as we can see on the right side of the slide. So we need to take this into account to assess the confidence that we place in results. Okay, so when we have many studies evaluating many tests, we can perform a network meta-analysis. Network meta-analysis is an extension of the pairwise meta-analysis that we saw before, that allows us to compare multiple tests in a single threshold, in a single framework. So for intervention studies, there is a very well-established background and methodologies, but when it comes to diagnostic test accuracy, there is less established precedent to extend it to test accuracy comparisons. So a reasonable question would be, why not to use the very well existing network meta-analysis models for interventions and apply them directly to diagnostic tests? And the answer to such a question is threefold. First of all, diagnostic test accuracy studies focus, as we saw before, on two quantities: sensitivity and specificity. So the models that are going to be used should account for both of them, including their correlation and the trade-off due to the threshold effect. Secondly, the index tests are usually evaluated in the same participants. So unlike interventions which are considered independent, for example, when we have an intervention study comparing two interventions, the group A is given the intervention A and the group B is given the intervention B, and these are independent. But in a study evaluating the accuracy of two tests, for example, test A and test B, the same participants will be firstly given the test A, and then the same participants will be given the test B. So there are dependencies and correlations that we should take into account. And finally, studies of any design can be used. So in interventions, studies are eligible for inclusion in a network if they compare at least two interventions. But this is not the case for the DTA studies. So we may have studies which evaluate a single test against the reference standard. So these are single test studies, but we also may have studies evaluating two or more tests. So the reference standard, we should mention, highlight that is not considered as a different test in the network, but it is considered only as a bridge. So, and let's see that in the next slides and how this is interpreted, incorporated in the network geometry. So this is a network of interventions. We have 4 different treatments which were explored in 7 studies. We have studies comparing, for example, the first study compares intervention B versus intervention C, and this is depicted in the network with a straight line comparing intervention B to intervention, linking intervention B to intervention C. The 4th study also compares intervention B to control, and this is also depicted in the network. So all interventions are drawn in the network, including the control intervention. Now, if we go to a network of diagnostic tests, now suppose that we have 7 studies evaluating 4 index tests, test A, B, C, and D. So we have the first study, for example, is a single test study. and explores test D, which is standardized against the reference standards. Now, if we see the test comparisons, the reference standard will not be included. So we denote that in the network with a circle, and in the circles tells us that there is one study, one single test study evaluating test D. For example, another example, the fifth study evaluates test C. And this is a single test study and denoted again with that circle in the network. The second study, for example, is a paired test study. So this explores the accuracy of two tests, test B and test C. However, even if test B and test C are standardized against the reference standard, then reference standard is not included and is in the test comparison cancels out. So the comparisons actually includes test B versus test C. And we denote that in the network using a dashed line connecting the two tests, test B and test C. For multi-test studies, for example, the triple test studies, the third study, we denote all these comparisons. We have test A, test B, and test C versus the reference standard, but actually we have three comparisons, A versus B, B versus C, and A versus C. And we denote that in the network using a closed triangle with solid line. Okay, so there are less established methods for performing a network meta-analysis of diagnostic tests. So to this endpoint, our aim was to identify the DTA, the network meta-analysis of DTA studies that compare at least 3 index tests, to review and summarize the characteristics of the models that had been used and compare their properties empirically. So to this endpoint, we performed, as we can see in the next slide, a scoping review, and we searched PubMed, Web of Science, and Scopus up until March 2021. So our search resulted in 10 methodological publications and 40 application papers, and we can see the distribution of the included articles across the years, and we denote in blue the methodological articles. We can see that were published pretty recently. So we found 11 models which were described in 10 methodological publications, plus the 2 hierarchical models, which are included in the 2 first lines. So these 2 meta-regression models are actually the models that we saw before that are described, the bivariate and the HS-ROC model, adding as a covariate the test type. So regarding the rest of the models, which were designed specifically for conducting a network meta-analysis of diagnostic tests, as we can see, most of them, actually all of them but one, were developed in Bayesian setting, and the majority of the methods required the joint classification tables of the tests per study, and almost all of them account for the correlation between tests. Only one method, the Meten-Lensaffer model, is a contrast-based approach, which allows to model paired and multi-test studies, but not single-test studies. So overall, the models that were suggested specifically for conducting a network meta-analysis of tests borrow strength across studies by simultaneously analyzing multiple comparative DTA studies, and they can all account for the between-study correlations between sensitivity and specificity, which correlations are reduced due to the threshold effects. Of course, the most popular were the 2 first that were broadly applied in the application papers that were located, the bivariate meta-regression and the HS-ROC meta-regression model. Okay, so we collected, as we saw in the flowchart, we collected 40 application papers in total, and we created a database of DTA networks. 83%, the majority of them, were published in general medical journals, and the majority of them were publicly funded as well. The median number of the studies included in the network was 32, and the median number of the tests included in the network were 5. So our goal was to empirically assess the DTA-NMA methods. So what we did is to apply the 4 Bayesian hierarchical DTA-NMA models and the bivariate meta-regression approach to all the available data that we were able to locate in the published application papers. So what we can see here is that overall sensitivity and specificity sensitivity is more or less the same, but meta-regression model was associated with higher specificity. The Niaga-Beta binomial model also estimated lower between study heterogeneity for both sensitivity and specificity, and the Owen model, which was the only one which allowed to include results on different thresholds, so that the inclusion of these different test thresholds may cause differences in results. So overall, the bivariate model, the meta-regression models have been widely used over the years, and this may be due to that this is a conservative approach and accessible to many review authors. But on the other hand, and most important, this approach ignores the within-study correlation between tests and assumes that studies reporting results on different tests are independent. So as we saw before, there are more advanced methods and models that have been developed, and most of them account for the correlation between tests within a study. And the network meta-analysis methodology for interventions, for the reasons that we explored previously in previous slides, cannot be applied directly to DTA studies. Then we can see in the next slide that there is not, we cannot say that there is a single valid method for DTA network meta-analysis. There is not a single model to apply and suggest. The choice depends on multiple factors which may influence the model. For example, data availability, the test thresholds, the study designs, or software familiarity. The meta-regression models ignores the within-study correlation between tests, and the selection between the methods may impact on the network meta-analysis results, especially for specificity, as we saw in the empirical assessments. And some of the models that were not evaluated require a joint classification table, and this may pose difficulties because this can be obtained by individual participant data, which are actually rarely reported in DTA studies, and we may face difficulties in obtaining them, and we may have data sharing problems. So finally, most of the detected models, as we saw, were applied within Bayesian framework, and this posed programming challenge and code availability problems, including convergence issues. And we need to say that we faced some that these models are time consuming. For example, the data sets with the Antigen COVID-19 test required more than 2 days to run the Niaga-ANOVA model. So now let's see a network meta-analysis of diagnostic tests, an example. So around a year or more, Health Canada and the Public Health Agency of Canada conducted us to lead a review and determine the most sensitive or the most specific rapid test for the diagnosis of COVID-19. They needed the report as soon as possible, so we set up our team considering the inclusion of policymakers, at least one clinician or content expert, 2 patient partners, content experts, research methodologists, and statisticians. So we developed our research question and determined the eligibility criteria. For the population, we considered eligible to be included adults and children that were screened and suspected for COVID-19. So the target condition was COVID-19 infection. As index tests, as eligible index tests, we included tests that were commercially available, for COVID-19, rapid lateral flow antigen and rapid molecular test. The reference standard was the PCR test. And for the study design, we considered eligible RCTs and observational studies that provided the 2x2 contingency table. The outcome of interest was sensitivity and specificity of the included tests. So as a second step, we developed our literature search with an experienced librarians, and this search was also peer-reviewed by another librarian using the PRESS checklist. We searched 3 major databases, and we included studies between December 2019 and September 2021. So we had time restriction issues, so we did not search for gray literature, and we also did not include any reviews or potential guidelines. We restricted our search to English publication with data, and we did not contact authors for any clarification or missing data. As a third step, and similar to the systematic review process that we saw before, we used a predefined, standardized screening form for both levels of screening. For both level 1, where we screen titles and abstracts, and level 2, where we screen full text articles. And we had a pilot exercise to calibrate the test and the form at each level of the screening with all the reviewers. But decisions, due to, as this was a rapid review, were based on a single reviewer. Then, for the on-screen completed screening, as a fourth step, we abstracted our data using a standardized data abstraction form, which was again piloted. And the decisions were made based on 1 reviewer who extracted the data and 1 verifier. So as a next step, we performed the data analysis and started with a basic descriptive summary of studies based on the contracts on the country of contacts and the type of the rapid test. We performed a random effects DTA meta-analysis using the bivariate model. And we also performed a random effects DTA network meta-analysis using the Niagara ANOVA model. We estimated and presented sensitivity and specificity for each included test, along with their 95% credible intervals. And we investigated heterogeneity visually by inspecting the forest plots. And we also performed subgroup analysis and meta-regression analysis to investigate how predefined potential effect modifiers may influence the DTA results. And we also assessed the transitivity based on the distribution of the above-mentioned effect modifiers across all the test comparisons. So when our results were ready, we sent the preliminary results and asked for consultancy on the key issues from our knowledge users. And we discussed implication of results caution and provided our knowledge users with a 1-page summary. And our results were reported using reporting guidelines to ensure transparency and completeness of reporting. These are the 2 network plots of on the left side, we can see the network plot for rapid antigen test, and on the right side, we can see the network plot of rapid molecular tests. Okay, and we summarize the results using forest plots. So in each network meta-analysis, we simultaneously compared all index tests and borrowed strength from the included studies, which increased precision in the DTA estimates. And our DTA-NMA results suggested for the rapid antigen test that the COVID Vero test had the highest sensitivity and specificity. And for rapid molecular test, the Expert Express test had the higher estimates. So both tests fulfill the WHO minimum performance requirements. Okay, so still there is room for improvement and a lot to explore. And we need to explore which factors may impact on the performance of DTA-NMA methods and explore the extension of ranking metrics to diagnostic tests. And as well, we need to explore how network meta-analysis assumption, for example, consistency, could be transferred to diagnostic tests. And so thank you all very much for your attention and presence here tonight. And we're happy to answer any questions.
Great, thank you so much both for your amazing presentation. So slide 28, format of the data says 2 by 2, but for the triple test study, this will be a much larger summary table, question mark?
Yeah, so that's a great point, I would say. Maybe I can start, Sofia, and you can add, I guess. So when we say the 2 by 2 table, we refer to the assessment of a single test compared, let's say, to a reference standard. So we found that, at least according to our experience so far, most of the studies report this 2 by 2 table. So for every test, that is compared versus the reference standard, but not between the tests. So if we have 2 tests, A and B, we don't have the results from A versus B. And that would be the joint classification table to have all the multitude of the results comparing A versus B versus the reference standard. So this is missing. We only have the 2 by 2 tables for A versus the reference standard, B versus the reference standard, and so on. I don't know, Sophia, if you want to add anything to that.
Yes. Have you come across any methods? So I guess if you only have A versus reference standard and B versus reference standard, we could call that having only aggregate level data, versus if you have the line by line A versus B versus reference standard for each individual, that could be considered IPD level data.
I wouldn't say IPD. I would. This is what Sophia called the joint classification table. The IPD would be for each individual patient. So we don't see usually in the studies that are being published. The individual patient level, we'll usually have to ask the authors and go through other processes for that. But yeah, and even the joint classification table is usually missing from these publications, from the DTA studies.
Are there any of the methods that you came across allow one to include studies that have both the joint classification table or IPD and only the higher level summary data?
So far, and Sophia, you can correct me, what we've seen is that most of those DTA-NMA models require either the 2 by 2 table or the joint classification table. We haven't seen any methods using both, either or, yeah. And unfortunately, that's the problem with most of these DTA-NMA methods. We do not usually have the joint classification table from the individual studies, and that's why we can't apply those methods. And we have to focus only on those methods that are using only the 2 by 2 tables. The ANOVA, that's a Niaga ANOVA model that Sophia presented, the beta binomial model that Sophia again presented. So yeah, those methods are, at least from what we've seen, have among the best properties, and they use the 2 by 2 table. So that's why we also applied those models as well in our review.
Thank you very much.
No problem.
So we also have Harlan, do you want to ask your ranking metrics question too, or should we skip that one about version of Sucra for DTA-NMA? Is there one out there, RG?
Sophia can answer.
Yes,
that.
well,
Yeah.
there is. Well, there is not currently there is not any version of Sucra for ranking diagnostic tests, but we may explore the metrics that have been published out for multiple outcomes and extend them to diagnostic test accuracy.
Yeah, currently what we can use to rank the interventions in a network meta-analysis of diagnostic test accuracy studies, what we've seen is the diagnostic odds ratio. So the diagnostic odds ratio uses both sensitivity and specificity. So we can use this one, for example, the DOR, the diagnostic odds ratio, to rank the tests. Sofia is working on extending the sucrase from interventions to diagnostic test accuracy studies. So hopefully we'll see that soon. And no pressure, Sofia. And there is also this index, what's it called? I can't remember. That we can also rank.
The superiority index.
Superiority index, yes. But
Yes.
again, this has several issues. So
Yes.
we wouldn't recommend using that.
And this is a vote counting method actually. So
Yeah, in our review, we use the diagnostic odds ratio to rank the tests.
Okay, great. Thank you. We do have a question from Zalalam. Did you want to ask your question in person, or should I ask it? Just wait.
Okay, I can ask it in person, no problem.
Great,
Thank you for the presentation. I'm just wondering because the reports for Public Health Agency of Canada and Health Canada were prepared using the Niaga-ANOVA model. Can we say that it is the best current method for DTA-NMA?
Yeah, so that's a great question. Thank you for that question. So unfortunately, we don't have any simulation studies to say that this is the best question, the best model to use. But based on what exists out there on the literature, and that we compared the different models that we found, according to their properties, we found that the Niaga-ANOVA and the beta binomial models have the best properties, and also we were restricted because we had to use models that use the 2x2 table, as I said before. Unfortunately, many of those models that exist require the joint classification table from all the studies, from all those tests, and these are not usually reported. So based on what we've found so far, these are the two, let's say, most applicable that we can use, and according to the properties that they have, let's say the best. But of course, we need simulation studies to make sure that this is correct.
Sounds great. Okay, thank you.
All right, well, thank you so much. That was such an interesting presentation, and I hope that we can get some further developments on your research in the future, maybe about those simulation studies that you're talking about.
Thank you, Carol. Thank you so much. Thank you, everyone.
Thanks. Yeah, thanks everybody for attending. It was a really great session, and hope to see you at a next Method Speaker series.